Welcome, everyone. My name is Elena Josway. I'm from Futures Without Violence, and welcome to session 2 of our 4-part learning collaborative that Futures is co-hosting with the National Center for Medical Legal Partnership. Today, the title of our whole learning collaborative is Collaborating to Address the Health and Legal Needs of Patients Experiencing Intimate Partner Violence and Exploitation. As folks continue to join and get settled, please share your location, your organization, or health center name if you're from a health center, and pronouns in the chat as we get to know each other over the course of this learning collaborative. You can go to the next slide. So just a reminder that both Health Partners on IPV and Exploitation, the project that's co-hosting this from Futures Without Violence and the National Center for Medical Legal Partnership, are supported by the Health Resources and Services Administration of the U.S. Department of Health and Human Services, and really grateful for their support and to be able to provide these learning opportunities to all of you. Next slide. And like I mentioned, my name is Elena. I'm from Futures Without Violence, and it's really wonderful to hear that some folks have already met some of our other projects through your comings and goings. Futures hosts the project Health Partners on IPV and Exploitation. And through that project, we work with community health centers to support those at risk of experiencing or surviving intimate partner violence, human trafficking, and exploitation, and to think about prevention, which we'll be talking about today a little bit as well. We do ongoing educational programs through learning collaboratives like this. We have webinars all the time, toolkits, a website with tons of resources. So encourage you all to check out our resources if you haven't had a chance already after the program today. Next slide. And we're joined by the National Center for Medical Legal Partnership. Bethany Hamilton is here. Bethany, do you want to say something about the center?
Sure, I'll be super brief, just in case folks weren't able to join us before or maybe on the webinar and we're new to you as a resource. We are a national training and technical assistance partner, helping health centers build and integrate and improve their medical legal partnerships, really leveraging the expertise of the legal field to help patients address and overcome those social barriers with legal underpinnings. So we will be continuing to partner with the Futures Without Violence on various initiatives. This is one, and we look forward to supporting you all in this learning collaborative as you take steps to really build your multi-sector partnerships as well. Thanks, Elena. And my team is also on, so folks from my team, Danielle and Catherine, are also on and joining us.
Go to the next slide. So just a note, we always start our presentation with a note that because domestic and sexual violence and human trafficking are prevalent, we assume always that there are survivors among us. And so we just like to share a reminder to be aware of your own reactions and take care of yourself first and step away from the Zoom if you need to. And then also to respect patients and client confidentiality in our conversations for today. And the next slide. The learning collaborative learning objectives are on the screen today. We will be identifying strategies to build partners. It says 111 because they're all important. That's actually a typo. So first is just to say that we'll be identifying strategies to build partnerships between civil legal services and community health centers. The big sort of goal and aim of this learning collaborative is to think and learn with all of you about what those strategies are and how we can continue to support those partnerships. We're going to describe strategies for sustaining and growing those collaborative justice responses to preventing and addressing IPV. That's going to be a particular topic for our next session, session 3. And then throughout these learning collaboratives, we're sharing tools and resources that can help community health centers and civil legal services partners formalize their partnerships, develop protocols for responding to domestic violence, and build prevention strategies. So today is session 2, and we're going to be talking with our colleague, our friend, Pat Medage from Colorado Legal Services, who I'll introduce in a minute, about building and developing those partnerships especially perhaps when they haven't, those types of partnerships haven't been formalized, or perhaps are informal. What are the ways in which developing those sort of collaborative responses can improve outcomes for survivors in your service areas? And then next week, we'll be talking with Alaska Legal Services about the model that they have built across rural Alaska, and particularly the ways in which that model is helping to address the justice gap in Alaska, and be thinking about the lessons learned for scaling and growing collaborative responses in your communities. And then the fourth learning session will be we'll be hearing from Indiana Legal Services about partnering to address the health and legal needs of older adult survivors, and they'll be sharing a bit more about their program. Next slide. So today we'll be hearing from Pat. And Pat, let me just introduce you really quickly, and then I'll pass it over to you. Pat Medage has represented low-wage workers and immigrant crime victims with Colorado nonprofit organizations since 1995. Pat currently is the co-founder and past president of the board of directors of the Rocky Mountain Immigrant Advocacy Network. And Pat is managing attorney at Colorado Legal Services, and has been an appointee of the Colorado Gubernatorial Human Trafficking Council since 2014. And I have just learned so much from Pat over the last few months of working on this project. So I feel really grateful, Pat, that you're able to join us. And with that, I will turn it over to you to talk a little bit more about your work.
Okay, thank you so much, Alana. Hello, everybody. It's nice to be here. Thank you for inviting me. I will talk a little bit about our organization, of course, and our partnerships. And we have a case scenario, so we hope to spend a lot of time in discussing that. So be ready to unmute yourselves when we get to that. And it's a pretty small group, so I'm looking forward to lots of discussion, since it's not a big group where we have to worry about about a lot of talking over each other or whatever. So I am with a statewide legal aid organization. So every state has organizations funded by a central funder, the Legal Services Corporation. And in the next two learning collaboratives, there will also be legal aid folks. So we provide free civil legal services to low-income individuals in Colorado. And just as a preliminary note, various crime victims, including individuals who have experienced trafficking or sex assault or domestic violence, are eligible for legal aid regardless of immigration status. So there's sort of a perception that we certainly do have rules about which non-citizens we can represent, but there is a very, very broad exception for crime victims. So please be aware of that, because people tend to dismiss the availability of legal services for that reason. So I head up, as Elena mentioned, our Survivor Services Unit, which a big part of what we do is representing immigrant crime victims in visa applications, also in helping them to report to law enforcement if they would like to, some civil litigation on behalf of trafficking survivors, and then a range of other civil legal services, such as name changes for safety or sealing records and so forth. So that's one statewide unit based in Denver. So we have clients all over the state. In the Denver office, we have various units, and then we have local offices around the state, which is very typical for legal services. The local offices deal with general legal issues, the general poverty law issues, such as housing or disability or public benefits or family law. And so I'm with more of a specialized unit. We have had both formal and informal partnerships. I have mostly worked on informal ones that I'll talk about a little bit. First, though, the formal ones. So people in other units have had formal MLPs, generally funded by an actual hospital or a health-related foundation. And it's interesting, the focus has varied depending on the attorneys involved. So there's not any sort of cookie cutter model for these partnerships. The first one was with Children's Hospital in Denver and focused a lot on having office hours at the hospital, a certain number of hours per week, doing guardianship type cases or powers of attorney and those sorts of documents, quite directly related to the healthcare issues. The second current one, it's a telelegal partnership, so it's mostly remote, and it's basically a pilot that will have, it's targeting rural areas. So the idea is there cannot be as much in-person contact, with Colorado being a very large state with a lot of, widespread smaller towns. So the idea is to have a remote setup. So they are working very close with a community health center right now in the Denver area, to the point that there are certain screening questions asked regarding vulnerabilities, and our attorneys are in the system and get automatically sort of certain referrals within the online portal, and so they can screen potential clients and potential legal issues, sort of without a lot of phone calls back and forth. They just sort of log on to the portal and see who's been potentially referred. So I personally have supported the formal partnerships by giving presentations and so forth. My focus has been on immigration issues, so often it's related to sort of the collaboration that is needed often between healthcare providers and immigration providers in the form of evidence that healthcare providers can help with in various types of immigration applications. But the informal piece has been more community, trainings and lots of contact with particular healthcare providers, particularly social workers with various facilities who know how to, who make referrals, who identify situations where we might be able to help and make those referrals. So we did have funding for outreach related to human trafficking, and one of our grant partners did a lot of outreach directly to healthcare providers. So that was a primary focus of that project, and a lot of referrals have come out of that. So our as I said, because it's more informal, we might get calls resulting from the scenario we'll talk about, or other similar scenarios where something doesn't seem right, and the provider would like to bring a legal services person into the situation to help provide more support. We also work with survivors of various crimes, as I said, domestic violence, sex assault, sometimes random crimes. We get other types of referrals, but the scenario here is a human trafficking related one. So I'll be talking a bit about human trafficking. Next slide, please. Oh yes, before that, so this is a sort of a random bathroom sign. I had occasion last year to take a friend to the emergency room, emergency department. And while I was using the restroom, there was a sign in the restroom, and I'm very sorry, it was like 5 in the morning and I didn't realize it was such a blurry photo. But I was really impressed that in the restroom, in the emergency department, there was basically this message to a potential survivor of trafficking that they could send out a plea for help. So if you've been forced to have sex in exchange for money, or are being held against your will and cannot call someone for help, please write your initials on the top of your urine sample cup with a red Sharpie. We can help you. Your request for help can be kept confidential, and only the medical staff responsible for your treatment will be informed. So I didn't even know it was there. I hadn't worked with this particular hospital. Clearly other organizations had, I don't know what the red scribbles are, by the way, so I can't explain those. Also, the Spanish has some typos and isn't the greatest, but I thought I would kick off with that just because I thought that was really neat, and it could focus a little bit more on being forced to work against their will. It mentions having to have sex in exchange for money. I would prefer it to have more about also, forced labor situations, or coerced labor. But anyway, I thought that was great. So next slide, please. I will just go into the plain language definition of trafficking in case anybody is unfamiliar with it. Sorry if you are. It's a crime involving the exploitation of someone for the purposes of compelled labor or a commercial sex act through the use of force, fraud, or coercion. When a person younger than 18 is induced to perform a commercial sex act, it is a crime regardless of whether there's force, fraud, or coercion. So basically with everybody, it's necessary to show force, fraud, or coercion, except when it's a commercial sex situation and a potential victim younger than 18. I will note commercial sex is actually defined very broadly. It's sex in exchange for money or a thing of value. So it could be, actually, I know someone in this situation, her mother offered her up for sex acts in exchange for the mother getting drugs. And that was sex in exchange for money or a thing of value to somebody. Somebody was receiving money or a thing of value as a result of that sex act. So that constitutes commercial sex. It's not just what you might think about as in what are sort of the stereotypes of a pimping situation or a brothel or a massage parlor. It can be a fairly small scale and still be sex trafficking. We can skip the next two slides. They are the more legal definitions. So I'm not going to go into them, but I included them if you would like to read more what the federal law states, how it defines trafficking. But I think the plain language definition is enough for this workshop. So some misconceptions about trafficking are that, to be clear, it is a crime of exploitation, not trafficking, or not transport, excuse me. So I think people equate it to, drug trafficking or arms trafficking, where there's some sort of movement, and the transport is not really the issue or important. Somebody could grow up in Denver and live their whole lives in Denver and be trafficked, so it doesn't require any sort of movement. As I mentioned, the criteria are force, fraud, or coercion. So force alone is not needed. I think whether it's sex or labor trafficking, there's often in the public a perception that the person is literally locked up or physically abused or whatever, and they can be quite coerced only in a psychological way, such as fear of harm to their family members or fear of deportation or fear of being arrested otherwise. So psychological coercion can be enough to create a trafficking situation. Not every smuggling situation is human trafficking, especially in the media. We hear about, a big trafficking ring was uncovered at the border and maybe it was really a smuggling ring. So smuggling is when somebody agrees to basically violate the immigration laws of whatever country, be brought to a country. And at that point, basically they're free. They've been smuggled in. Yes, it's not legal, but it's also not trafficking. Trafficking happens when they're after the crossing, they're under some sort of control, or they're being forced or coerced to provide labor, including sexual labor, including commercial sex and so forth. There's all kinds of labor exploitation that's not trafficking. It may well be illegal, but I always encourage a broad view. The issue is not just whether it's trafficking, but what other labor violations might be going on that need to be addressed, and that the connection can be made to a legal provider or a community, worker rights organization or whatever other organization to address the labor exploitation. And in our scenario, there are different violations that come up in that scenario as an example. Similarly, except for minors, with adults, not all prostitution or sex work is trafficking. Adults involved in commercial sex work consensually do not meet the definition of trafficking. It's trafficking when they're forced or coerced or tricked into providing that sex work. Minors, of course, if they are involved in commercial sex, it is trafficking. Next slide, please. So there might be scenarios where a patient, I think most of you are healthcare providers on this call, where a patient might be victims of various crimes, sex assault, domestic violence, other types of interpersonal violence. So why is it important to identify trafficking? One reason is in a lot of parts of the country, there is special case management. So service case managers who are trained in trafficking issues know the resources and can help find different support and help, set up a case management plan with an individual. And it's not universal throughout the country, but it's available in a lot of places in the country. For immigrants experiencing trafficking, the identification is important because there's potential immigration status, particular to human trafficking, that can result in refugee type benefits. And those benefits include Medicaid. So basically they would qualify for the same benefits a refugee would get. In most of the country, victims of other crimes, such as sex assault, domestic violence, kidnapping, various other crimes, might be eligible for immigration status, but it is not attached to these sorts of benefits. So this obviously is huge in the healthcare situation. And a lot of the inquiries I get from our health community partners are somebody who has no sort of assistance. It needs, is in some serious health situation and has no sort of health care, and they're trying to identify any possible way for them to get status and potentially get Medicaid and other support that requires documentation. So that is a huge issue. Unfortunately, a lot of people don't have much of a way, but we try to be flexible in providing those consultations and identifying whatever we can. Again, if trafficking, that it can be very helpful. Sometimes it's, all different types of immigration issues. Human trafficking is a federal and a state law. Every state does have anti-trafficking laws. So if the individual does want to be part of a prosecution, they have recourse both in state law and in federal law. We do not pressure an individual to report the trafficking, but we just let them know where about, and we let service providers know, including healthcare providers, know that we're not the government. We will keep your information confidential, and we will tell you about your options without pressuring anybody to report or not. But if they did want to, there are more laws that protect them than compared with, again, maybe domestic violence or sex assault or whatever. There is the federal law as well. The law, or at least the federal law, provides a right to sue the trafficker, as does our state law. Some states probably don't, but there could be potential litigation against the trafficker, which is a reason to identify human trafficking along with possibly other crimes. And there's mandatory restitution, which means they should get compensation in the course of a criminal case. So back to the criminal cases, they should get restitution. In the case of a lawsuit, they could get damages, which means they could be compensated for emotional distress and so forth committed by the trafficker. Another reason to identify it is simply that it's under-identified. The scenarios can be gray, difficult to identify. In most cases, it's not going to be identified right away. but being aware of the red flags and finding resources to potentially identify trafficking is helpful because it is under-identified, and therefore there's not strong data about the prevalence of trafficking in this country or really elsewhere. I'm sure there are other reasons that you might think about. Feel free to chime in if you have thoughts about other reasons for why it's important to identify, but those are a few. Next slide. So we have a case study. Andre is a 27-year-old man presenting with a severe cut on his hand. He speaks limited English and his manner is rather guarded, so he does not volunteer information. You learn, however, that he works as a prep cook and dishwasher at a restaurant and cut his hand laying linoleum in the apartment above the restaurant. He walks with a limp. You learn that he fell from a ladder 3 months ago while working and still has a sore knee. The restaurant owner did not provide treatment for his knee or hand injuries. You also learned he lives in one of the rooms above the restaurant. So then in the next slide, we have discussion questions. And
we do. We do. Pat, do we want to just scroll? I just want to make sure we roll back to the case study first, just to give folks a good chance. If you are neurodiverse like me, sometimes you need to read anything 2 or 3 times or you're slower because everything distracts you along the way before you reach the end. So I just want to make sure we leave this up on the screen. Also, Pat, apologies for the little delay for me getting back on, but I just want to make sure everyone knows that when we do get to the discussion questions, we would like you to unmute, speak, but if you do prefer using the chat, use the chat, and we're going to stay together as a group as opposed to going to breakouts because we're a small, intimate bunch here and can have a really robust discussion together. So feel free to use the chat, and Elena, Pat, and I, as well as the other folks throughout, will help to stare or read out what comes through the chat. I could use, let me just, while folks are taking an opportunity to read the case study again in case they need to, I was actually trying to upload to the Zoom platform the excerpted case study in case it's helpful to anyone to have it available to them on their screen. So hopefully everyone got a chance for us to move into the discussion, because we're going to scroll to the discussion now. And just send us something in the chat if you need any one of us hosting today's event, especially Catherine and Danielle from the NCMLP team. We can share the case study with you via email if you need some assistance. All right, so based on what Pat shared in the case study about Andre's situation, I'm trying really hard not to drop any hints about what we'll explore here. What we're going to do is have a discussion about what is it like to learn about this information, and then develop or strategize or think about a next step. The assumption is that Andre is with a healthcare provider in an exam room sort of setting or a healthcare delivery setting. And so it's very likely the case that if you're from healthcare, you're probably going to speak up first and share some of your perspectives. But we encourage everyone, legal services, social services, DV advocacy services. We know we have foundation folks on, share what your perspectives are about what the next steps might be. And in sharing your perspectives, please, please, please tell us what your role is. That way we are treating ourselves here as a learning cohort together, and can collaborate in this learning and sharing beyond the learning collaborative events. Talk about some challenges that are inherent to taking the next step. What are some of the red flags that you might identify as you learn that information? And then how are you documenting and sharing information about what Andre has shared with you? We'll then continue the discussion with identifying some of those external partners, as this session really talks about developing those partnerships. So let's utilize what Pat shared about her particular partnership in Colorado to think about what partners you would involve in the community in helping to take that next step. And then for the partners that we might identify, what can they do? Or if you are speaking on behalf of one of those identified partners, what can you do? And then finally, we'll end on trying to figure out, if you don't have a partnership as yet, formal or informal, how else might you support Andre? Or if you do have a partnership, right, what are the other types of interventions? And what about prevention strategies that might be there? And then we'll share some takeaways. Let me pause to see if anyone has some initial questions. I think thanks, Pat. We got the case study pasted into the chat. Let's kick off the discussion. Anyone want to take a stab at sharing? There's no right or wrong answer here, I think, about what's the next step that you would take? And we can, sorry,
I'm sorry, I'm on Sheril's computer, and so I'm guessing how okay, I guess I got it unmuted.
You're good.
Okay, I was wondering if, this might be a little sophomoric, but finding an interpreter, but preferably maybe a Spanish-speaking social worker. That's what, off the top of my head.
Mm-hmm. Tell us who you are, since you're not Cheryl Carrington.
I did put in the chat so people wouldn't think she has a multiple personality disorder. So we're classmates. We're both doctoral students at University of Southern California. So that's and my capstone is going to be around medical legal partnerships, and so that's what I'm doing. Learning.
Excellent. So. Thank you for joining us. Really appreciate that.
Thank you very much for doing this.
So we kicked off with, first of all, identifying Andre's perhaps need, right, for translation and interpretation services, depending on, the nature of the engagement and the referrals. Pat, any response to that, or anybody else want to continue to share reactions to that?
No, absolutely, I agree. I kept the example ambiguous, so I just said limited English, could well be Spanish, but yes, identifying the language and providing interpretation, which my understanding is should be pretty widespread in the healthcare setting, maybe not as much with a social worker, but absolutely. This might not be a conversation that could happen in the exam room, but hopefully, yes, there could be social work staff or others who can follow up.
Anyone from the health center world want to share perspectives about that particular suggestion related to services for a limited English proficient individual who has come into the health center setting, and there's a suggestion to provide translation interpretation services? Do we have health center folks on today? I have to scroll back to see who joined us. Any FQC or lookalike folks with us? Maybe not today.
So Megan and I work for a public health serving organization that is neither clinical nor academic, but partners in all of those places. So we are constantly navigating the is this our lane? Is this not our lane? How do we best serve this person? So I think my first kind of response, first of all, I completely affirm, yes, how do we serve this person and their most acute needs, and also how do they best get served, and can we provide that or no? We are almost never in a setting where we have translation, but maybe some of our clinical partners would be, and that's very exciting. I guess my next question is, for myself, would be in what context am I encountering this person, and how safe are they right now? Because at least in our work, we could be encountering them any number of community locations for HIV testing or other STI testing. We could be encountering this person through the context of maybe a parental advisory group or a community advisory group, and not in the context of this at all. Or we could be encountering this person as a research participant, and in which case all of our IRB protocols would also be engaged. So my next question is, what is my role inherent?
Yeah, so
how do I get
that would be my next question for you. What do you see as your what next step would you take? Because you gave three very, very unique examples of interactions. Using any of those or any combination
Yeah,
what would you do next?
my literal role is to pick up what other people had to put down. Sometimes they call me a project manager. So my next move almost always is going to be to call our in-house mental health and social work department and say like, hey folks, I've got somebody who maybe needs a psychosocial assessment for safety. Could you tag in?
And what were the red flags for you, Jen?
I mean, the inexplicable injuries for the context of what the work is expected to do, like and also just the proximity of all of this. Like, I don't love that the building is happening upstairs. I don't love that we might live on site. I just have questions about agency, big questions about agency when somebody's experiences are localized to that small of a geography.
Mm-hmm. It's great observation. Great observation. Pat, do you want to, and Elena, want to tag on to that?
Yeah, thank you. You've definitely touched on a lot of them, and including like why is a prep cook laying linoleum? I mean, that can happen a lot, that they're just used and exploited in whatever way. So that's definitely a red flag. And I forgot to say this is based on a real case, and the individual eventually became also head cook along with all the rest of this. So he did like everything in the restaurant.
And Elena, I know labor issues that's your jam. I don't even know I should call it your jam, but this is your thing. Do you want to add on to that as well?
Yeah, I mean, I think this scenario for me also, raises a question about, for all of you who perhaps do have experience working on cases related to labor trafficking, what have been some strategies that have been helpful in referring someone to a partner in a case like this, where perhaps it isn't necessarily very clear that it is a case of human trafficking, but you do have some instincts. I think Jen sort of raised these feelings that we have that just based on our experience that, yeah, maybe there's something else here. So I'm always curious about, with labor trafficking, because there's this gray area, how do you even have that conversation with your community partners who may not have as much experience, in working with folks who are experiencing wage theft, or working with folks who are experiencing labor exploitation, or working with folks who have experienced labor trafficking? What is that call like? What do you share? And is a case like this an opportunity to have more conversations about what our community-wide interventions are, or education is related to labor trafficking? So that's where my mind went a little bit, is just thinking about, what would if I'm calling a DV service agency about a case like this, because I know that they have services that might help support someone who's experiencing human trafficking, what would I share? What would I say to try and make that referral successful?
Jen, I'm not sure if you shared with us what would be a next step. So let's say you did, you engage with this person, the red flags came up. Who would you call next?
Yeah, so my response there would just be that without any more details about how I'm encountering this person, my call would be to our in-house mental health and social work department.
Okay.
Because they are best trained and best capable of assessing how critical someone's situation is, and then doing a warm handoff for services.
And then what would that, just to give folks a sense, because I've seen on discussions where people are developing MLPs, they're like asking, the various either internal partners or external partners, whoever they're going to be referring people to, what are the sorts of questions that you're asking? So could you walk us through like your rationale, or do you have a sense of what the social worker that are, or the internal partners, the internal teams, what they might be doing next? Or what
I
information
am
would you be
not-
sharing? Let me take a step
Yeah.
back and say, based on what Elena just walked us through, what information would you be sharing with them?
In most of my roles with my organization, I'm a mandatory reporter, and all of my training tells me, therefore, that I am not an investigator. So the things that I share are what is factual, just details. These are the things that have been shared with me. These are the reasons that I believe that there may be more going on. And then back to whoever I'm sitting with, I'm going to do everything that I can do to share with my colleagues to offer you support, but I'm not disclosing this information any further than just my own team. So
Okay.
making sure that the person still feels safe with me, and that I'm not necessarily engaging entities that they might not feel safe with. Systems involvement in New Orleans is a really big issue. So no, not never, just not for me. And then I unfortunately can't necessarily speak to what all of the questions asked in the psychosocial assessment would be, just because, one, I'm not trained in that capacity, and two, we attempt to have a very clear division of lanes where we can, so that we have a clear responsibility where it's necessary.
I'm sure that resonates with a lot of folks, including, interestingly, while we were going through this inquiry, Callie shared in the chat, that she works in a hospital. Not sure if that's what I was referring to as a health center. So let's say, for example, just stemming from what's been shared so far, that at some point, or we can even go back to, Pat's example where you started in the healthcare setting, and assume this was an FQHC. For health centers, if we're just generally referring to health centers through this Learning Collaborative, we are referring to the Section 330 Public Health Service Act, community health centers, or federally qualified health centers of the, there are various types in the health center program, or the health center lookalikes. And they have a specific set of requirements, such as enabling services, which includes translation and interpretation services. And so they'll have that capability built in to their mission and their mandate as a part of the health center program, to provide those specific types of services, plus screen for legal services. However, what they ask and what they share can vary, just like Jen's example, right? Certain staff may ask certain types of questions. That's their specialization. You're not quite sure exactly what the referred to entity may ask. And I think this is where, it's very similar and runs parallels to an external referral. So, such as if you were going to refer to Pat at Legal Services. So I do want to see if I can utilize Callie, who conveniently put herself out there in the chat, to ask, in the hospital setting, what would you be able to share some of your perspectives as well? So what you would do, are there external partners or internal partners that you would reach out to?
Yeah, I work in a pediatric hospital and a domestic violence organization. I think if this was a parent, for example, that presented in the emergency room, it would be a challenge to our team. I think it would be the social workers that would probably engage the medical legal partnership. But I think really what we're talking about, the first step, is to potentially link with some sort of services. I know that our DV advocacy services would not help this person, not because they wouldn't want to, and they would certainly consult with me, but they focus on family violence and not these type of issues. And honestly, I know we have some human trafficking organizations, but I'm not as familiar with them. And honestly, I think they're more focused on sex trafficking than labor trafficking, although I'm sure it happens in our Midwest town. So I would also utilize social workers to try to hopefully connect with an organization if the person was interested in that. I think one of the challenges is even getting somebody to agree to that, getting this person to agree to additional. And then also I was just even thinking about making that connection. Even just following up with that person the next day is going to be a challenge potentially, much less trying to connect to multiple resources. So it might even make sense to just build that relationship. I've had social workers say, well, you have to come back for a checkup in 4 days. I'll be here too, and I'll connect with you then, and then maybe make that referral versus immediately trying to say like, oh, you need to talk to all these people, which we struggle with, social workers wanting to help, but then, the person has to be invested. We can't decide what they need. They have to decide that to some extent. I mean, we can help, but I think that would be a challenge in this situation.
Thanks, Kelly. And also, yeah, since he is, in the case of Andre, he is in the situation. So even if he wanted to do something, the people around him need to be careful. Sometimes the first response with various community members is to request a wellness check later. Maybe not, hospital staff, but somebody involved. And that can be problematic, can result in retaliation against the individual. Police come, do the welfare check, and the worker's under pressure to say, oh yeah, I'm fine, or the employer's there and will retaliate against the worker later. So it's definitely tricky when they're still in this situation.
Actually, I have a question for Pat that Callie's comment raised for me. Just thinking about this example and just the amount of time that engagement with someone that it might take for someone to feel comfortable coming forward, and then after that, just thinking about the amount of time that some of the legal interventions that you mentioned, Pat, take. In your partnerships with other organizations, is that something that you all talk about, that the partnership may not be as simple as picking up the phone and calling and sending someone over, and then that's the extent of the amount of time that the two partners will be collaborating or working together or supporting the same individual, right? Like, this could take years. And do you, for everyone, but for Pat as well, are there strategies for thinking about like the duration of some of those parts, the amount of time that this work really takes, and what's the benefit in talking about that up front with our community partners versus 2 years later? Does that question make sense, what I'm sharing?
Yes, for sure. Thank you. Right. So when there's an initial referral to whatever organization, the entity making the referral might not be involved long-term, but certainly with the follow-up, absolutely, there's very long-term, it is a long-term prospect, whether it's an agency complaint or, the Department of Labor or a workers' comp case, so even if it's not trafficking, but if it is trafficking, the law enforcement that might investigate it, or a civil lawsuit or an immigration, it's all very long. And we're fortunate we have had the federally funded case management organizations here. And there's a bit of a balance to be had. We try to be as candid as possible, obviously with the client's consent, to talk about what the timeframes are, because they need to plan like how long their money can last and how much support, if it's going to be. Sometimes it's emergency, someone moves to another state, it's very short, the services are of short duration. We might be involved as the legal provider for years, but the agency might be involved very short term because somebody's moving. On the other hand, it could be, years, as you said. And we try to be candid about how it's looking. At the same time, we are cautious about providing too much information. There have been case managers who sort of second guess the legal work, which we don't appreciate. So we don't certainly give them in-depth information about the ins and outs of whatever the legal case that results. Also, we're very careful about not communicating in writing, because if there is a civil suit or a criminal case, they could be subpoenaed, and even if they have confidentiality practices, they could be subpoenaed, and the communication might violate attorney-client privilege. So the long-term relationships can be complicated, but we just, plus with turnover, there's constant retraining. I'm probably stagnant because I've been doing this for 26 years, but a lot of the other people in the community, are there for 2-3 years. So it's a constant process of education on all of these issues. Sorry, that's a really rambling answer, and I don't know if it addresses even your question or your comment, but it's about relationships for sure with all of those service providers, and it's usually more after the initial referral, but in the longer term services.
Pat and Elena, what you all raised, and I think there was also a question, there's a hand raised. I'm just going to let everyone know, just unmute whenever you're ready. But what Pat just shared, I think, is why we like to highlight the benefit and value of formalizing the partnerships. When you operationalize it, institutionalize it, you have created systems that are embedded into the delivery systems at these various settings, legal, DV advocacy, social work settings, healthcare settings, that can stay and remain sustain, generally speaking, despite staff departures or turnover or funding, right, changes, you won't be as hard hit by the funding challenges because you've really baked it into your delivery system and models. And then you're able to continue to specialize, because I'm thinking about what Jen mentioned about, this is what I know, this is my lane, right? But not letting that silo, or not letting that stay in that lane become a silo. I wanted to, let me pause for a moment and see if folks have some additional questions or thoughts. There was a question on Cheryl Carrington's screen. And then I think something in the chat, Megan's. Thanks, Megan. You want to share what's resonating with you, Megan? And then Cheryl, I'm sorry, Cheryl, go ahead, and then Megan will get to you. Are you muted? You're back muted.
Sorry, it's really Margaret, and I'm Sherelle, so that's Margaret.
Oh, Cheryl,
yes.
and then Margaret.
Okay. Hi, I'm Margaret, the scapegoat. No, this is actually kind of a very specific question, but for those who work in these clinics and hospitals, for the umbrella of confidentiality, I mean, would it be helpful bringing a social worker in on the get-go because they have a whole separate confidential agreement? Would that engage the patient and make them feel more comfortable? Or does, in a hospital setting, is it like an umbrella of confidentiality? So I didn't know if that was one of the benefits to having social work in, from the get-go. Is that, so I guess I'm asking, what's the issue with confidentiality in social workers in group settings like clinics and hospitals?
Anyone want to share some? I can share some MLP perspectives, but I want to see if someone knows, as they will, on this question much more than I do. So let me share some initial MLP perspectives, because you have these various provider types with degrees of confidentiality due to the clients or patients served. These pertain to our ability to practice as depending on our different professions, as well as the records that are retained, these visits, right? Where in the healthcare settings, HIPAA comes up for those of us that are attorneys. We have attorney-client privileges, Pat and Elena and others may have mentioned. For social work, same or similar, right? For MLPs, one of the core components is, first of all, having agreements in place to really understand what role these different partners play and what limitations and restrictions might become sort of hindrances to being able to share information. And in addition to having those sorts of things worked out in agreements, you're also working out as partners what you're going to do to be able to share information to still be able to assist the clients or patients. So you might agree as partners to limit the amount of information to be able to assist Andre specifically with the labor issue. And then when outcomes on that legal intervention is shared, maybe it's very limited and with Andre's consent built in. And we've seen certain MLPs work on electronic exchange of data to allow this to happen, and with consents provided by Andres, right, as the referral is made and then as the outcome is reported back, and still protecting those various rules related to confidentiality that we all have to adhere to in our different settings. Pat, I don't know for the various types of partnerships that you engage in, if you want to, I'm sure you can add to that, actually, Pat, I'm sure you can.
Well, I would just say that we don't necessarily need a lot of information. If the individual would like a consultation, we will respond to a request. Hey, can you consult with this person? And we don't need a lot of details, especially if we have a trusting relationship and we know that, you know, the service provider probably has something that, or the healthcare provider probably is aware of something and knows that there's and thus there is a reason for that referral. So that's one thing. The other is it's pretty routine with especially the social services providers and including domestic violence advocates. It's pretty routine that they get the release, they send it to us, and it's all fairly smooth. Again, assuming the individual consents, and often if the caseworker or the clinic staff member, whoever is trusted, they're somewhat inclined to trust us as well with that the referral, and as I think Jen said, sort of the warm handoff.
Mm-hmm. There's a way to leave Andre out of this perhaps and deal with this more systemically. So I just want to note in the third bucket, there are some prevention strategies that folks might think about, aside from the specific case-by-case intervention to assist Andre in his specific situation. Perhaps this employer actually needs education and doesn't want to be, Pat, I don't know what the outcome was here with this actual employer, but perhaps in fact, right, there are employers who really are just in need of education and support and guidance and will improve situations for their employees. And you can have an impact on every single employee under that, in that restaurant setting. So let me pause and see if maybe we can get Megan to share what resonated, and I'll turn it back over to Elena and Pat. And if anyone else wants to share, please feel free to do so.
Thank you. I was just thinking about, I also work with Jen at the Institute of Women and Ethnic Studies down in New Orleans. And this whole conversation resonated with me because I started out working in HIV prevention, and now I'm actually entering into the social work role. So like I'll soon get my master's in social work. And so in looking at the case and trying to figure out next steps, naturally, since I've been a prevention coordinator for so long, my natural step would be, oh my goodness, we're going to reach out to the social work team like that. We don't have the capacity to meet all the needs of this person. But now that I'm in this space where I'm literally going to be into both roles, it really makes me think more about like the intentionality that we have when we create partnerships, and then also what is my next step now that I'm receiving training on both ends, and how can I advocate for both sides when we are in the middle of partnership building? And there are many partnerships that we may have on the prevention side that we may not even think about that translates into the mental health side or the social services side. So it was just very eye-opening and just incredibly helpful because it's a different view of the work.
Really great to hear that. Thank you for sharing, Megan. Appreciate it. All right, let me turn it back over to Elena and Pat to see if we can share some takeaways and take us home.
I'll let Elena take us home, but just on prevention, first, on the worker side, individual, just education, having information about their rights available to them, however it is, in a waiting room, through, social media and so forth. The Colorado's got a campaign going through thisishumantrafficking.com that our state council did. We actually did work as part of our outreach program. We did work with the State Restaurant Owners Association and got them materials about what trafficking is. I don't know if any particular restaurant owner responded to that, but that is one example of a prevention effort. Because people maybe cut corners and don't realize, well, actually this might be a crime. And you might not want to be dealing with being part of a crime. So I'll leave it at that in the interest of time.
Yeah, thank you, Pat. I think just in terms of takeaways, yeah, you were going where I was going, worker education and just community outreach and education about human trafficking, but also just about wage theft too, right? And the forms of exploitation that may not lead to human trafficking, since I felt that in this story as well. And then thinking about the DV programs out there that may not be serving survivors of labor trafficking, are there programs out there that are like doing worker work readiness programs or workforce development programs that perhaps could also be places to engage in conversations about your rights as a worker as you're entering the workplace as well? Maybe that's also a place to have some sort of conversation about that, or even about, for folks from clinics and hospitals, about the services that your clinics and hospitals provide as well, for people experiencing some of these victimizations. And then the other thing that I took away just from this conversation is just about the quality of our relationships with each other and how important that is to being able to work together long term when cases take a long time, or even just being able to trust that your partner is referring someone over here and they saw something that they need help, and they don't necessarily need to send you an email describing it all, but that you have a trusted relationship with them enough that you know that that's what something's going on, and so that's why you're being engaged, right? That to me also felt really resonant. You can go to the next slide. This conversation for us today was very much about starting these partnerships, informal relationships. For our next session, we'll be talking about scaling, formalizing, and sustaining medical legal partnerships with a program that has several formalized medical legal partnerships around their state. So I know that there was questions for folks about, how to sustain them, funding strategies, data, measuring your impact. And I think really hopeful that in the next couple of sessions, we'll get into some of those questions as well. And just to say that there's an evaluation link on the side, please feel free to fill it out. It really helps us. And just thank you all for participating, for sharing your work. Thank you so much to Pat for sharing your work and for the 26 years that you've been doing this work, and for being a resource for all of us as well. So with that, I think I'll close it out and let you all go, and thank you all and have a great rest of your day. Hope to see you next time.